this is probably one of the most important videos I can do. My hope is that any dentist that treats long-term care facility people in their dental office watches this. McLaren's category is a small tool that allows you to know your patient better. Without it, you're risking your patients. I also hope all POAs, family members, if you're an administrator, DON, director of nursing, charge nurse, this is critical information to know about dentistry, and it is a clue. University of Iowa, McLeran came up with this category in 1989. You can research it in oral health. Excuse me, this is too important to go without. Oral health for older adults, and then just type in McLaren's, M-C-L-E-R-A-N. And this was first written that I saw it when I first started out in '99 in a Homestead School continuing education course on oral health for older adults, and it went over McLaren's categories and totally changed my life, and has probably kept many patients safe that would have been more at risk had I not known this. Category 1 is a patient is completely self-sufficient and able to perform oral hygiene techniques with possible exceptions of flossing due to fine motor ability. Category 2 of McLaren's is a patient is self-sufficient but unable to adequately perform techniques due to arthritis, limited range. This would be people that live with their kids, a mom or dad that lives with their children. Category 3, patient is unable to care for daily needs dependent on others to perform oral hygiene procedures, but can cooperate with caregivers. And category 4 is patients comatose or completely dependent on others for self-care, non-cooperative or combative. And that non-cooperative, we have a lot of patients that would love to help us but can't. You know, they just can't do it. In my practice, my wife and I sat down and tried to figure out, okay, how many category 1s do we have? We have none in our long-term care practice in nursing homes here in Oklahoma. We have a few number 2s. We sat down and said, what percentage would be number 2? Well, we could count and think of one person. So we're going to say maybe 5% because I just want to be generous in the category that we treat 5% category 2. Category 3, patient is unable to care for daily needs, dependent on others, but can cooperate. We probably have 50 to 60% of our patients in category 3. Category 4 would be the rest. In private practice, I would say from 76 to 99, I had probably 99% of mine category 1, patient is completely self-sufficient. Category 2, where they're limited a little bit, I maybe had a couple, not many. And those would be the seniors that were living there. It's important to know that this category is not standalone. We have to use it with other factors. And an 80-year-old or 90-year-old living at home or living with their parents is a category 1. That's what all dental schools teach. That's what most dentists are used to treating. They don't know how fragile it can be. I went to a nursing home, studied the chart. We're going to take out a tooth. I knew the patient. Inadvertently talking to the staff, and 2 weeks before, the son had picked up his mom and broke both legs. Well, they had told me she was bedfast and we'd have to do it bedside. No problem. You know, I knew she had severe recession and there were other things that, but after she broke both legs, it alerted to me, I'm going in and I'm going to hold her jaw, take a big shiny instrument and crank. Well, what we did is we smoothed her tooth that was creating a sore in a tooth instead of removing the tooth. But in the dental office, I had a hammer I saw that would have been a nail, and I would have had to have taken that tooth out. But I wouldn't have known my patients. And because I go over McLaren's 3 and I follow certain different things, I was alerted to cautions. I was talking to the staff. I had read her thick medical record. I knew her weight. I knew her medications. I knew all of her diagnosis, but it's only because I could go into the nursing home and find that out did I see that. If she'd been brought in with a POA or different things like that, I may have never caught that if she'd been in a wheelchair and had a blanket covering her up. So we need to know our patients, know McLaren's. It is a tool, but it is to be used with a DNR. It's critical as a dentist or as a care provider or in treating somebody that you know if they're a DNR or not. Are you willing to treat a person and do the dentistry that we do on our category 1 and 2 people on a category 3 or 4? Because you cannot resuscitate. You cannot call 911. You know, it's just go out to the waiting room and tell the family, I'm sorry. You know, I misjudged how stable they were or what was going on. So we use it with DNR. We use it with weight, with meds, with allergies to penicillin and things like that. That's one of our big guns in treating. If they've got diabetes and we treat them, or they're on Coumadin and Plavix, we try to do a simple filling and there's profuse bleeding and you can't get that filling to seal. So what, you do 5 or 6 fillings that fall out in 6 to 8 weeks, and now you've drilled a hole that's made it bigger and more susceptible to decay. And now if they live the full 4 years in a nursing home, which they might, you've now created more problems than you cured in just leaving it alone or having had the tooth non-restorable. It's also important to know how long in your state our nursing home stays. And I've covered this before in other videos. In Arizona, it's 6 months because they have so many services that come to the house. In Kansas, it's 2 years. In Oklahoma, the best results I can see are 2 to 3 years. In my practice, we think we get 4 years because they don't put both my mom and dad passed within 3 months in a nursing home. Well, they wouldn't have been put on my panel of patients. So I get the healthier ones. That's why I think my patient load, I lose 25% of my patients a year, 20% of those to death. 5% do they move, they go to skilled, they transfer buildings, they go back with the kids, and that is just an important factor for a dentist to know. Another important thing is for the dentist to visit the nursing facility, read the whole chart, talk to the daytime charge nurse, maybe the DON or the med nurse, hang around, maybe go at dinner time and observe them. Are they at a feeder table? What are they like during the day, and not when the POA has them out with an event where they're up, their adrenaline's flowing. They may be almost comatose the rest of the day once they get back, but this is an event. They got out. It's the great escape. They are up and wired, but what happens if they go down when they're in your dental chair and you can't finish a procedure you've started? Know your patient, doctor. And POAs. Every POA that I seem to have ever had tells me, oh, mom's healthy, and then I look and they're on 20 meds, they've got end-stage renal disease, and they don't know how this affects everything. They say, well, sure, she's healthy. Every time I come, she's happy, but when you leave, is she the same person? And that's why families need to be involved in home care, because that puts the importance on it. Once they leave, they refuse. In fact, my mom, I asked her, how's the food? And, oh, great. And I turned around and I was listening to her talk to a staff member, and she was telling him how the food is like slop around here. I get one story, the staff gets another. That's what happens when we age sometimes. So know your patients, know the one you're caring for, be safe. McLaren's is a critical tool. It's not the only tool. There's a dozen other things you use. The oral surgeon, don't ask them these questions. They use the ASAPS. You can look that up on the internet. They use the surgical categories. They have other things and other fish to fry. So be safe. This is Dr. Randy Grill, Nursing Home Dentist. Thank you.